Meningitis by Amjad Ali (BS/N, RN). Meninges. The meninges refer to the membranous coverings of the brain and spinal cord. There are three layers of meninges, known as the dura mater, arachnoid mater and pia mater. Meningitis infections of the central nervous system (CNS) can be divided into two broad categories, those primarily involving the meninges meningitis, and those primarily confined to the parenchyma encephalitis. The meninges refer to the membranous coverings of the brain and spinal cord. There are three layers of meninges, known as the dura mater, arachnoid mater and pia mater. Meningitis is an inflammation of the lining around the brain and spinal cord caused by bacteria or viruses. Bacterial meningitis is caused by bacteria. Meningitis can be the primary reason a patient is hospitalized or can develop during hospitalization. Transmission is by direct contact, including droplet spread. Transmission occurs in areas of high population density, crowded living areas, and prisons. Prevalence and fact: with almost 4,100 cases and 500 deaths occurring annually in the United States, bacterial meningitis continues to be a significant source of morbidity and mortality. The annual incidence in the United States is 1.33 cases per 100,000 population. Newborns are at highest risk for acute bacterial meningitis. After the first month of life, the peak incidence is in infants aged 3 to 8 months. Causes: meningitis is most frequently caused by bacterial or viral agents. Risk factors: skull fractures, brain or spinal surgery, sinus or upper respiratory infections, use of nasal sprays, individuals with a compromised immune system. Pathophysiology: most cases of meningitis are caused by an infectious agent that has colonized or established a localized infection elsewhere in the host. The organism invades the submucosa at these sites by circumventing host defenses, e.g., physical barriers, local immunity, and phagocytes or macrophages. Invasion of the bloodstream and subsequent seeding is the most common mode of spread for most agents. Meningeal seeding may also occur with a direct bacterial inoculate during trauma, neurosurgery, or instrumentation. The blood-brain barrier can become disrupted. Once bacteria or other organisms have found their way to the brain, they are somewhat isolated from the immune system and can spread. When the body tries to fight the infection, the problem can worsen. Blood vessels become leaky and allow fluid, WBCs, and other infection-fighting particles to enter the meninges and brain. This process, in turn, causes brain swelling and can eventually result in decreasing blood flow to parts of the brain, worsening the symptoms of infection. Replicating bacteria, increasing numbers of inflammatory cells, cytokine-induced disruptions in membrane transport, and increased vascular and membrane permeability perpetuate the infectious process in bacterial meningitis. Complications: brain damage, hearing loss or deafness, hydrocephalus, loss of vision. Diagnostic study and evaluation: lumbar puncture. In general, whenever the diagnosis of meningitis is strongly considered, a lumbar puncture should be promptly performed. Examination of the cerebrospinal fluid (CSF) is the cornerstone of the diagnosis. Moderately elevated CSF pressures, elevated CSF protein level normal 15 to 45 mg per deciliter, decreased CSF glucose level normal 60 to 80 mg per deciliter, or 2/3 of the serum glucose value, elevated white blood cell count, usually increased 100 to 10,000 per cc, with predominantly polymorph nuclear leukocytes. CT scan. A screening computed tomography (CT) scan of the head may be performed before LP to determine the risk of herniation. Blood studies. In patients with bacterial meningitis, a complete blood count (CBC) with differential will demonstrate polymorphonuclear leukocytosis with a left shift. Chest radiography. As many as 50% of patients with pneumococcal meningitis also have evidence of pneumonia on initial chest radiography. Cultures and bacterial antigen testing. The utility of cultures is most evident when LP is delayed until head imaging can rule out the risk of brain herniation, in which cases antimicrobial therapy is rightfully initiated before CSF samples can be obtained. Medical management of the patient includes crystalloid infusion. If the patient is in shock or hypotensive, crystalloid should be infused until euvolemia is achieved. Seizure precautions. If the patient's mental status is altered, seizure precautions should be considered. Seizures should be treated according to the usual protocol, and airway protection should be considered. IVT and oxygen administration. If the patient is alert and in stable condition with normal vital signs, oxygen should be administered, intravenous IV access established, and rapid transport to the emergency department (ED) initiated. Pharmacologic management begin empiric antibiotic coverage according to age and presence of overriding physical conditions. Sulfonamides, tetracyclines, carbapenems, fluoroquinolones, glycopeptides, aminoglycosides, cephalosporins, third generation. Antivirals, systematic antifungals, vaccines, inactivated. Inactivated bacterial vaccines are used to induce active immunity against pathogens responsible for meningitis. Corticosteroids. The use of steroids has been shown to improve overall outcome for patients with certain types of bacterial meningitis, such as H. influenza, tuberculosis, and pneumococcal meningitis. Osmotic diuretics, mannitol may reduce subarachnoid space pressure by creating an osmotic gradient between CSF in the arachnoid space and plasma. Loop diuretics, furosemide is a loop diuretic that increases the excretion of water. Anticonvulsants. Anticonvulsants are used to help aggressively control seizures, if present, in acute meningitis, because seizure activity increases ICP. Nursing management. Assessment of the patient with bacterial meningitis include neurologic status. Neurologic status and vital signs are continually assessed. Pulse oximetry and arterial blood gas values. These values are used to quickly identify the need for respiratory support. Nursing diagnoses. Major nursing diagnoses include 1. Risk for infection related to contagious nature of organism. 2. Acute pain related to headache, fever, neck pain secondary to meningeal irritation. 3. Impaired physical mobility related to intravenous infusion, nuchal rigidity and restraining devices. 4. Activity intolerance related to fatigue and malaise secondary to infection. 5. Risk for impaired skin integrity related to immobility, dehydration, and diaphoresis. 6. Risk for injury related to restlessness and disorientation secondary to meningeal irritation. 7. Interrupted family process related to critical nature of situation and uncertain prognosis. 8. Anxiety related to treatment and risk of death. 9. Risk for ineffective therapeutic regimen management. Nursing interventions. 1. Monitor vital signs and neurological signs. 2. Assess for signs of increasing ICP. 3. Initiate seizure precautions. 4. Monitor for signs of meningeal irritation. 5. Perform cranial nerve assessment. 6. Assess peripheral vascular status. 7. Maintain isolation precautions as necessary with bacterial meningitis. 8. Maintain urine and stool precautions with viral meningitis. 9. Maintain respiratory isolation for the client with pneumococcal meningitis. 10. Elevate the head of the bed 30 degrees, and avoid neck flexion and extreme hip flexion. 11. Prevent stimulation and restrict visitors. 12. Administer antibiotics as prescribed. 13. Assess neurologic status and vital signs constantly. Determine oxygenation from arterial blood gas values and pulse oximetry. 14. Assess blood pressure. Usually monitored using an arterial line for incipient shock, which precedes cardiac or respiratory failure. 15. Rapid IV fluid replacement may be prescribed, but take care not to overhydrate patient because of risk of cerebral edema. 16. Reduce high fever to decrease load on heart and brain from oxygen demands. 17. Monitor daily body weight, serum electrolytes, and urine volume, specific gravity, and osmolality, especially if syndrome of inappropriate antidiuretic hormone (SIADH) is suspected. 18. Prevent complications associated with immobility, such as pressure and pneumonia. 19. Institute infection control precautions until 24 hours after initiation of antibiotic therapy. Oral and nasal discharge is considered infectious. Thank you. Subscribe my YouTube channel.